Very good afternoon. Myself, Sandeep Sahu, working as a professor in Department of Anesthesiology, Sanjay Gandhi, PGI, Lucknow. My special interest in emergency and trauma, and I am very thankful to the organizer to giving me task, role of balance crystalline in trauma hemorrhagic shock. इस बारे में मैं ये कहना चाहूँगा कि हम सब आज कोविड के जिस दौर से गुजर रहे हैं, कोविड से जितनी डेथ होती है उससे ज़्यादा मॉर्टलिटी और डेथ देश में होती है। पर डे 250, 250 डेथ और 2.5 लैक्स डेथ पर ईयर बिकॉज ऑफ ट्रॉमा। हम कोविड के लिए बहुत कुछ कर रहे हैं, लेकिन हम ट्रॉमा के लिए क्या कर रहे हैं? वैसे प्रिवेंशन की बात मैं कहना चाहता हूँ कि हम क्या कर रहे हैं, लेकिन मैं कहना चाहूँगा कि जब ट्रॉमा मैनेजमेंट की बात है तो शॉक के मैनेजमेंट में हम क्या कर रहे हैं? As balance anesthesia to balance life, we try to practice in anesthesia with component of hypnosis, relaxation, analgesia, that is a balanced anesthesia, and we are trying to maintain a balance in our life. कुछ ज्यादा ना कम, अगर ठीक ठीक चलता रहे, हम 2021 तक बचे रहे कोविड में ड्यूटी करते हुए भी, तो मुझे लगता है कि हमारी लाइफ का बैलेंस है। ऐसे ही बैलेंस रिसक्सटेशन में हम कितना फ्लूइड देते हैं, एक बड़ा क्वेश्चन है। फिर दूसरा क्वेश्चन है हम कितना ब्लड फ्लूइड देते हैं, और फ्लूइड ही देना चाहिए कि हमें कुछ और देना चाहिए, हमें क्या देना चाहिए, या हमें बैलेंस रिसक्सटेशन करना चाहिए। आज पूरी दुनिया जो कि ट्रॉमा में गाइडलाइंस बनाती है, चाहे अमेरिकन हो या यूरोपियन हो, सब ये कह रही हैं कि हमको 1 लीटर से ज्यादा फ्लूइड इंट्रॉप ड्यूरिंग रिसक्सटेशन, स्पेशली द रिसक्सटेशन फेज ऑफ ट्रॉमा नहीं देना है। अब हम पहली इस चीज को मैं आपको जस्टिफाई करूंगा और फिर बात करेंगे कि क्या देना है। तो इवोल्यूशन ऑफ रिसक्सटेशन फ्लूइड हुआ है जैसे जैसे हम इवॉल्व हुए हैं, फ्रॉम हेटा स्टार्च टू टेट्रा स्टार्च। इन 1940s में नॉर्मल सलीन आया, और आज 2020 में अगर हम बात करें, हम एक बैलेंस्ड एनेस्थीसिया, बैलेंस्ड एनाल्जेसिया, बैलेंस्ड लाइफ एंड बैलेंस्ड क्रिस्टलाइट की बात कर रहे हैं। और इसके आगे के भी इवोल्यूशन की बात करेंगे तो मोर पीएच गाइडेड फ्लूइड की बात करेंगे। हम जानते हैं कि हमारा ब्लड 55% प्लाज्मा है, और प्लाज्मा खाली पानी नहीं है, और 46% में सेल्स, रेड ब्लड सेल्स, व्हाइट ब्लड सेल्स, प्लेटलेट है, और प्लाज्मा प्लाज्मा में 90% पानी है, तो वाटर वी कैन से, बट बाकी बाकी इलेक्ट्रोलाइट्स हैं, बाकी कोagulation फैक्टर। तो क्या जो हम फ्लूइड दे रहे हैं वो हमारे ब्लड के इक्विवेलेंट है? क्योंकि मुझे ये पता है कि जब ब्लड के दो काम है, स्पेशली एक तो ऑक्सीजन ले जाना, तो ब्लड में आरबीसी वो ले जाती है, कोई भी आईवी फ्लूइड नहीं ले जा सकता। दूसरा, उसमें कोagulation फैक्टर प्लेटलेट हैं जो कि कोagulation का काम करते हैं, जो कि कोई भी आईवी फ्लूइड नहीं कर सकता। तो ब्लड, बिल्कुल खून का बदला खून, यही है जब हम सक्सेसफुल ट्रॉमा शॉक, या तो हम खून निकलने ना दें प्रिवेंशन से, या हम ब्लीडिंग जल्दी बंद करें ट्रॉमा में जल्दी ऑपरेशन करके, या हम बैलेंस्ड रिसक्सटेशन करें, हीमोस्टेटिक रिसक्सटेशन करें, ताकि ब्लीडिंग जल्दी बंद हो, उसकी ऑक्सीजन कैरिंग कैपेसिटी बनी रहे। और उस बीच अगर हमको प्लाज्मा का 90%, जो 55% का 90% पार्ट है प्लाज्मा का, जो वाटर है, वो वाटर इज इंट्रा, दैट इज अ डिफरेंट वाटर, that plasma constituent is different, it is not any IV fluid constituent, and it can never be still in 2020। हम जानते हैं कि we when we give fluid and we take fluid from the body, it comes from the intravascular space, and we never want to take the intracellular space water or interstitial space water, because when we take this, the resuscitation goes irreversible and cell goes to death. Whatever we give, we want to give this should be isotonic to the plasma, because if this is isotonic to plasma, the my cells that is having a protein covering that will survive, and when they survive they will do their work. When they are not going to survive in hypertonic or hypotonic saline, they will not do its function. This table shows that plasma tonicity is around 290, in between 290 or 300, and sodium chloride is in a balance of 140 and 1100, and chloride is 4. So intracellular extracellular things are different. Sodium is more extracellular, but tonicity is 280. And if we see different fluid from up to down, ringer lactate is almost osmolarity, but it's not same osmolarity of plasma, slight hypotonic. But it has sodium and chloride that is not as much, but it's near to plasma. But normal saline is 0.94, saline is having osmolarity is 308. So plus 20 of the plasma, but sodium, it only have sodium and chloride, that is 154, 154. So what you give when your trauma patient come? List is there. You give dextrose, DNS, ringer lactate, NS, half NS. Come to this table. This table says that normal saline is only having 154 chloride and sodium. That does too much. So it doesn't have other thing like potassium, calcium. The ringer lactate is having almost sodium and chloride that is equal to plasma, but it has lactate because the normal lactate is less than 4 in plasma. So after this, third type fluid that we should can give is a balanced salt solution. Balanced salt solution is having sodium less than the normal saline 140, chloride almost equal to plasma around 100, and it has potassium equivalent to plasma, but it has other things because when we try to decrease the chloride 98, जो कि 110 लैक्टेट के आसपास है या 153 sodium chloride में है, तो we have to add other things to make a cation anion balance, and here we have added acetate and gluconate to make it less chloride containing. So what is your choice? You are trying to balance your life, your patient, or you give without thinking. When we give normal saline, like if you give 1 liter, 250 goes in the intravascular space, other goes in the one interstitial space, 750. And this is never a choice worldwide. People say normal saline is not normal because it is not normal equivalent to plasma. It gives you more chloride, it gives you more sodium load. And worldwide, nobody using normal saline, perioperative, in ICU, and resuscitation. 5% dextrose containing fluid, if you give 1000 ml, only 80 ml go in intravascular space, rest go intracellular, 670 ml, 250 in the interstitial, and this is for nutrition, this is not for resuscitation, all dextrose containing fluid. When you are using albumin 100 ml, it remains in the interstitial space. If you have given like 220 ml, it will 100 ml, it will remain in intravascular space, so it will increase the oncotic pressure, it will keep bind fluid here. But when you give balanced salt, the balanced salt solution has sodium almost equal to 140, chloride 98, potassium 5, gluconate and acetate in place to decrease the chloride, and osmolarity is almost equal to plasma. When you give this 1000 ml, it almost remain in the intravascular space, and gluconate is excreted, acetate is metabolized to CO2 and bicarb. So this is almost more physiological. Now balanced salt solution is coming whether we are giving either only two things we can give now, means if according to plasma, because this is the final picture I want to show. This is our plasma. The sodium 140, chloride around 100, the bicarbonate 25, albumin around 23, calcium, magnesium, and potassium in this ratio. But in normal saline, it is have only chloride and sodium 154. 154 means this is not equivalent to plasma. It will increase metabolic hyperchloremic metabolic acidosis if you are using more. No data says how more, but definitely if you are using more than 1.5 or 2 liter in 24 hours, this can increase the sodium. The ringer lactate is the second most or most common used fluid for resuscitation till the balance fluid was not there, and they are having same constitute equal to plasma chloride around 110. They have calcium, but lactate is definitely more. If it is a liver dysfunction or liver failure, then lactate will not be metabolized. It will accumulate, it produce lactic acidosis. So balance solution, that we make the balance equal to plasma, sodium equivalent to plasma, chloride almost equivalent, and in place of lactate we added acetate and gluconate, magnesium, calcium, and now the calcium is also coming in balance. So it is making a balance equal to plasma. Another questions. Now the question is clear. We have to either give balanced salt solution or ringer lactate, but lactate has a limit, so better to give balanced salt solution. And this is literature from worldwide in trauma patient. Another thing, that when a patient come in hypotension to your emergency, to your ICU, to your OT, the patient is having around 30 to 40 or 50% blood loss. And here the hypotension occur only when it is 30 to 50% blood loss has already occurred. And 50% blood loss means 50% coagulation factor gone, 50% platelet gone, 50% PRBC gone. And what we are giving? Pani pani. No pani. We have to give similar constitute that give oxygen carrying capacity, that give a coagulation factor, that give platelet, and make a homeostasis of coagulation and oxygenation. Because if you are giving more water in place of blood product, it is causing acidosis because of shock, coagulopathy because you are doing dilutional coagulopathy, and you are giving fluid that is not 41 degrees centigrade. It is causing hypothermia. So this is the lethal triad. This will lead your patient towards die during resuscitation or later on because of organ failure. So we have to do damage control resuscitation. Damage control resuscitation means we will control bleeding by early resuscitation, by early patient shifting to OT, patient stabilizing in ICU. We will not delay or deny OT in this patient. We will use permissive hypotension. We will use prevention, so no trauma occur. We do early treatment, pre-hospital treatment. We will prevent acidosis, hypothermia, and coagulopathy. We will treat hypocalcemia. We will early transfuse blood product. We will restrict fluid, not 1 or 2 liter. 2 liter is more. Nobody in world is giving 2 liter fluid nowadays in trauma patient in coming in shock. They give only 1 liter. Give early blood product, shift the patient in OT for damage control surgery and damage control resuscitation. So what is the goal of fluid resuscitation? We want to control bleeding. We want to restore blood volume. We want to have better tissue perfusion and organ function. So what should be our blood pressure? We can keep 60 to 70 systolic blood pressure in penetrating trauma. In blunt trauma, 80 to 90. In traumatic brain injury, 100 to 110. We don't need blood pressure more than this. If you will keep this more than this, the blood clot will dislodge and will again do secondary bleeding. And only give fluid when it increases stroke volume and cardiac output. Means who is seeing this? You have to monitor. You have to apply monitor, at least clinical monitor. Main arterial pressure should be around 65, 70. Systolic blood pressure in the range of 60 to 110, depend on blunt, penetrating, or traumatic brain injury. And lactate should be 1 and 2. That we can do. So pulse pressure variation, systolic volume variation, systolic blood pressure variation, volume variation, and stroke volume variation, we can say, and passive leg rest test are the correct market to monitor. So what are the evolving strategy? There are two strategies. Earlier, immediate aggressive fluid resuscitation, not good, that we are doing till now. Because when you give more fluid, it causes cardiac complication, overload, pulmonary complication, GI complication, coagulation disturbance, electrolyte disturbance, hypothermia, and more fluid causes abdominal compartment syndrome that lead to AKI, lifting of the diaphragm, and reduce the venous return, and that diaphragm are shift upward and decreases chances of extubation from the ventilator. So what are the good strategy? Good strategy is delayed resuscitation. Means fluid is given after bleeding is controlled. or permissive hypotension. Means fluid is given to increase systolic blood pressure 60 to 90 without reaching normotension. When you are, especially when in penetrating trauma, जहाँ चाकू घुसा है या आपका कुछ फाड़ के कोई चीज अंदर गई है, that is penetrating trauma, and here if you are keeping blood pressure less than 90, the survival chance are more. Patient will can reach from pre-hospital the site of this incident to the hospital. Means scoop and run is beneficial in penetrating trauma. Don't waste time in pre-hospital, in transport, in admission. Immediately shift this patient to the OR, OT, and that's the role of anesthetist. Resuscitize and take in the OT, take in the ICU. The other is low volume fluid resuscitation. Here, during permissive hypotension, maintain only tissue perfusion. Means systolic blood pressure 80, 90. Permissive hypotension, when you are keeping say 80 to 90 systolic blood pressure and mean of 40 to 60, most of the animal studies said that you are reaching the goal directed resuscitation. So either low volume or delayed fluid resuscitation are the only two strategies. Permissive hypotension is very beneficial. Means if you are keeping your blood pressure, systolic blood pressure 80 and 90, you are decreasing blood loss, you are decreasing bleeding, you are decreasing abdominal hypertension, you are decreasing acidosis, you are decreasing coagulopathy, and you are improving chance of survival. All the international guidelines say restrict volume replacement. Don't give fluid, balanced fluid or ringer lactate one lot more than 1 liter. If you need one more than 1 liter, give blood product, FFP, platelet, cryo, platelet concentrate, and especially in traumatic hemorrhagic shock. So you have to reduce patient transfer. So all trauma patients should reach within 10 to 15 minutes to hospital. If it is taking more than this, then we should think of whatever I have said, two strategy, either low volume, delayed resuscitation, or hypotensive resuscitation, and use damage control resuscitation. Means permissive hypotension, hemostatic resuscitation, and damage control surgery. And my dear friends, this is worldwide practice. Why not we can do worldwide practice in India? This lecture is not only to listen, this is to act. If you believe that I am saying this all is true, then we have to make this true thing in our clinical practice. So this is damage control resuscitation. Permissive hypotension keeps systolic blood pressure 80 to 90, not more than that. Minimize use of crystallite, not more than 1 liter. If you need more than 1 liter, this patient is great for shock. It needs as early blood product of 1:1:1, means FFP, platelet, and PRVC. First FFP and platelet, not PRVC, not PRVC. Because we all putting red bag. वो लाल बैग टांगते हैं और उसको 4 घंटे में चलाते हैं. That is having only 250 ml of PRVC. Once the bleeding is controlled, then only we have to give PRVC, because this will only carry oxygen carrying capacity will increase after 24 hours. And most important, early hemorrhage control, that can only be help to our surgical colleagues in orthopedics, in cardiac surgery, in general surgery, that we take the patient, all trauma patient in without any investigation except blood grouping, directly to operation theater, and after that to the ICU. So water better, definitely lot of studies are there in international. We don't have to India do all this study again. Crystallite or colloid debate is there. Definitely crystallite. Saline versus albumin, colloid versus crystallite, crystal study, chest study, safe study. All saying that crystallite should be used preferably. Normal saline is not big no, because it is not normal. It has high chloride that cause especially renal failure perioperatively or during resuscitation or hyperchloremic acidosis. Dextrose containing fluid are for giving nutrition and energy. This is not needed DNSD5 in trauma. Hypertonic saline is especially in traumatic vein injury when you give less fluid and it causes osmotic diuresis, but not routinely. So what we should use? We should use balanced crystallite or balanced crystallite that is available earlier the ringer lactate. Colloid is a big no, because perioperatively it has been seen that it's not good to use albumin or HES, especially in traumatic vein injury, because increases risk of kidney injury. But if anyhow you have to use, The natural one is good, means albumin display that displays the renal protection is good, but not good in traumatic brain injury. Except so you can give in trauma, but this is not preferred. Preferred is the crystalline. So final take home message: we have to do hemostatic resuscitation. Hemostatic means we have to fill the lost blood products from our body with blood and blood product with a combination of plasma platelet first, then PRBC 1:1 ratio. We have to prevent coagulopathy. We have to prevent dilutional coagulopathy by giving excessive crystallide or colloid. And don't give colloid because they again increase the coagulopathy. And we have to improve survival by early use of antifibrillary agent, that is tranexamic acid 1 gram, loading within 3 hours of the arriving of the patient or within the trauma, within the golden hour the patient when the reaches to us. And we have to use only 1 liter of ringer lactate or balanced salt solution for resuscitation. And tranexamic acid will make a strong clot. It will not weak the clot. And hemostatic monitoring means we have to see the vitals, the stroke volume variation, the pulse pressure variation, if possible, to target the uh, our resuscitation. It's not only the blood pressure. And once patient in shock, and we have to use blood product, we know that 3.5 of liter of 5 liter is the blood volume, and whatever we are giving 1 bag, 2 bag, 3 bag is not enough. We have to call for massive transfusion protocol. Thank you.